We're very happy to have Sijo Parekattil with us. Sijo is a very a good contributor to our network. He's a specialist urology. He's a specialist in urology and is managing post-vasectomy pain syndrome in his practice.
Thank you so much, guys, for the opportunity. And, I love being part of this group. And, Doug, really want to thank you for inviting me initially. And, he's been an inspiration. I always want to emulate my practice like his. So thanks, Doug, for, giving me a chance always. I'm a urologist. I'm based out of Orlando. And I have a real interest in chronic testicular and groin pain patients. And so if there's any patients out there you have with post-vascular pain syndrome, or you need some help in managing them, I'd be glad to provide advice and any guidance I could give you. Um, Vasectomy is definitely a great procedure for contraception. And when you look at it from a community standpoint, it really is one of the safest options for a couple when considering different contraceptive methods. And so I always talk to patients and kind of frame it in that way because, obviously I see the worst of the worst because the patients I get are guys who are pissed off, upset after getting a vasectomy, might have some regret. There may be a psychosocial component. There's a lot of mixed feelings and anger and frustration by the time, I see many of these patients. And I think what I always try to remind these patients is that, listen, you made the right decision, and when you look at it truly from a risk perspective, I really think that vasectomy still is a very, very low risk procedure compared to, for example, the female counterpart getting some type of contraceptive methods as well. Because when you really look at the literature, it's actually quite comparable, if not, safer. But but having said that, there are a small number of patients that get that do have quite a few issues, and so sorry, my 2 year old is trying to get into the conversation as well. I apologize. So, but uh, but basically, I feel like when sorry guys. So, so basically, what I usually quote patients is that the risk of chronic post-victim pain is anywhere from as low as less than 1% to some studies have gone up as high as 15%. Now, what exactly is chronic post-vasectomy pain syndrome? And I know there's been a lot of discussion initially about this initial post-inflammatory reaction and then delayed pain and stuff. But what I think we're talking about when we talk about true post-victim pain syndrome is somebody who's maybe 6 months, a year out, who's having debilitating pain, chronic pain, sometimes unilateral, bilateral, really unable to kind of function normally. And these are the guys that we're talking about. They do exist, and that's the problem, is that there's a few of these individuals that really are quite affected by this, and you know, subjectively and objectively seem to appear to have had a completely normal life before this, and then after the vasectomy, now start to have quite debilitating pain and dysfunction. So these are the individuals we're talking about. Now, we did a study about 5, 6 years ago where, now this is the only study that's really compared uh, true post vasectomy patients to healthy normals. And we took about 50, 60 individuals with chronic pain from varying degrees or causes, idiopathic post-vasectomy pain syndrome, post-inguinal hernia pain, um, some sports athletes, and then individuals that had no pain, but we were operating for other reasons. So, for example, guys who had testicular tumors who had no pain, but we were doing a complete radical orchiectomy, and then also men that we were fixing varicoceles on who didn't have pain. And so we did a pathology study where I did about 50 or 60 biopsies from different areas of the spermatic cord while I was doing the procedure real time, and then compared it to the guys that, for example, a radical orchid was simple because we were taking the whole sample out. And so I had the pathologist actually look through the neuroanatomy to see if there's any difference between guys who have PVPS or chronic groin pain issues versus healthy controls. And what we found was in about 84% of the guys who had pain, they had some structural changes in 2 or 3 specific nerves in the cord. We found Wallerian degeneration in some of the sensory nerves in the cremasteric muscle layer, the perivasal sheath, and the posterior fat component, versus only 20% in healthy normals, people who had no pain, but we were operating for other reasons. So that's, quite significant. This was not a minor difference, and it was reproducible across all 3 groups: the post-hernia patients, the post-vasectomy pain patients, and the idiopathics. And what's interesting about that is that it may indicate that there's a small group of guys out there that have some type of propensity to developing pain in this area, some baseline abnormality. Now, what causes this, we don't know. A lot of these guys had back issues as well. So maybe there is some nerve component where there's a mild nerve compression or nerve root issue, or it might be a congenital anomaly where these guys just have a hypersensitivity. And so I think what might be happening is, and that might explain why a very small percentage of individuals who do get symptoms have symptoms kind of out of proportion to what's going on. What's also interesting is when we look at the guys with PVPS, it doesn't seem to, as many of you have alluded to already, that doesn't seem to correlate to the technique that was used or the experience level of the surgeon that did the vasectomy. It really seems to be, it doesn't really seem to be based on that. And so I think there could be a small cohort of these individuals out there that have this propensity. And so I think when we're counseling patients to get a vasectomy, we just tell them honest truth that, hey, there's a small percentage of guys that have intractable pain. Unfortunately, there's no true way to really predict who's going to get this pain, but it's a possibility. And if they do end up getting these issues, there are some treatments down the road. We generally go in the direction of conservative treatments initially with medications, neuromodulators, and then eventually, if they are really not getting better after 6 months or a year, can go down the road of doing like a vasectomy reversal or blocks or targeted denervation. And I'm sure you guys have seen our posts. We've got a whole slew of different treatment modalities that we can pursue if it gets to that point. But my goal today was really not to give you guys too much of a spiel, but kind of leave it open as an open discussion. And so with that, I'll kind of end there and kind of open up for questions.
Well, let me thank you. See, we have some people talking. The best way to raise your hand is on the computer, but I did see you, Nick. So but if everybody else can either send me a note, or you can actually, there's a raise your hand device. If you go to participants on the bottom, it says raise hand. So please raise hand, let me know. But in the meantime, John Gilbo from the UK already raised his hand, and I'm going to give him the first chance to speak. John Gilbo is in the UK. So Luis, I'm sorry, there he goes. John Gilbo is about to be.
Hi, everyone. Great to see you all. We ran the Elliott Smith Clinic starting in 1970 in Oxford and did 40,000 men up through until about 10 years ago. And we did 2 prospective studies on this one study, which continued and was reported on twice, on initially 488 men who agreed to be followed up as an audit of this pain. Because the real problem is that so often studies are retrospective. They're just patients coming along or being compared with other patients with different pain in a retrospective way and not prospective. So what we found, first of all, very interestingly, was that 45 out of 488 men in the start of this prospective audit of vasectomy had pain already. They in their questionnaire, do you ever get pain in the scrotal area? Amazingly, 9% of them said, oh yeah, I do get pain there from time to time. And then when they had their obturations, really fascinatingly, half of them got better. They didn't get that scrotal pain anymore when they were asked 7 months later whether they had scrotal pain, no longer had it. Not suggesting that vasectomy cures scrotal pain, but it's an intriguing finding. And I think it probably means that quite a lot of reports of discomfort after vasectomy is really just that. And maybe it's quite common to have it, and it's not what we're really needing to be too worried about. However, I entirely agree with Sijo. There are some men who get really bad pain sometimes. And we found that at the end of 7 months follow-up, we found that there was, I think, 4 men who had their lives somewhat impaired, really impaired. They actually felt this pain was interfering with their lives. And then when we continued the follow-up to 5 years, which is a long time, we then found that the overall rate was 2 in 300. And I think that's a pretty good one to go on, because I think it isn't the perfect follow-up, but at least it's prospective. So something like 1 in 150 of pain that really interferes with life is something you could quote fairly solidly. By the by, these papers are published, one in the British Journal of Urology International in 2007, and the other is available on my own website at the moment, Eco Time Capsule, but I can make sure you get the references later if you want to look them up. The other point to make is that we showed statistically significantly that post-operative chronic scrotal pain is reduced significantly if you do it by no scalpel vasectomy, because 2 of our 9 surgeons continued to do the technique with a scalpel, the old style form of vasectomy. All of us used the hyfricator to heat seal the end of the vas. So there's a similarity in the techniques ab initio, but the group who used the scalpel, the group where the 2 surgeons used the scalpel, had more of this discomfort, which we found as a rate of about 10%, by the way, or the really nasty cases as well, were less likely in NS3. So those are our findings, and I won't go into any more now unless you want to ask questions, but I think ours is the only prospective audit at the moment, although I'm encouraging the Associated Surgeons in Primary Care here in the UK, and Gareth James is in charge of that, to do an audit for longer, if they could, than they have so far. I think their audits have only gone on for about 6 months or so, but we need to do an audit for at least 2 years, I'd say, or preferably 5 years, and with, if possible, even better follow-up than we have. But those are numbers that you could conjure with. Something like a 10% risk of mild discomfort, probably comparable to sort of pain that some people get even without a vasectomy, like talked about to start with. And then it's sometimes quite annoying, but not interfering with life. And 2 in 300 we found, which is 1 in 150 rate of pain that interferes with life. And my final question for Sijo is, I noticed you mentioned vasectomy reversal, and I have sent you an email, which you won't have had time to see yet, by a chap called Edwards, who reported that what he used to do for his 7 cases, I think, of bad pain in Australia, we're talking ages ago now, and he seems to have worked, was to do under a local anesthetic to free up the lower end of the vas, so that the sperm could come out just under local, not reversing the procedure because the chaps wanted to stay sterile. And he claimed that just freeing up the bottom end so that the sperm could come out there, and then the reticular endothelial system would deal with the problem, was enough to take these really bad pains interfering with life to make them better. Do you think that might be comparable to doing a complete reversal, which is somehow taking pressure away? And have you ever done just that?
Yeah, so we do have a number of guys that show up with, they get pain, and then the initial surgeon converts them to an open-ended vasectomy. So kind of the same technique, kind of opening up and freeing up the pressure. It does help in some individuals, but there are some individuals that actually get worse, because if it is true neuropathic pain and there's a nerve component, sometimes the more we muck around in that area, the greater the chance of making these, and these patients get really pissed off, because that's the danger with, once they're kind of in that pain mode, now they're in a different kind of category. And so anything we do on them, it just has to be done kind of carefully. And so I kind of give the patients all the options. If it truly seems more like neuropathic, meaning that the pain is on one side, doesn't seem to correlate to ejaculation, things like that, I'll usually do a cord block first and see if they get better temporarily. And if they do, then I'll do a targeted denervation, and I go up higher in the groin, and I stay away from the scrotum, just in case, it might be a nerve component. And then, but you're right, if it's purely ejaculatory pain, pain that kind of gets worse after ejaculation and stuff, a lot of times the reason I kind of lean towards reversal is it's a lot of it's patient driven, because maybe there's a lot of guilt and feelings of, hey, I just want to be put back the way I was. And so I think you're right. I mean, we probably get away with just converting them open-ended, but many of them just want one procedure and be done with it. And they're just like, look, I regret my decision. I want to go back to the way I was. And so I think you're right. I think a lot of times we go in the direction of the reversal more to because the patient's kind of pushing in that direction. So, and then if I think there's a nerve component, then I go the denervation direction.
Well, that's really useful to hear. And I'm sure the whole thing is got to be tailored to the individual. There are going to be different options for different men. Can I just ask you about the use of gabapentin or something like that as a treatment of neuropathic pain?
Yep, I think that's a great idea. And so initially, I agree there's this kind of inflammatory response that guys get a few weeks out. So you're right. I don't think we necessarily need antibiotics, but some of the antibiotics do have an anti-inflammatory component as well. So, you know, I know a lot of physicians just kind of prescribe that initially just to kind of help them out. And one of the rationales of doing antibiotics first is that the next line of treatment would be probably steroids and things like that. So if you have any doubt of infection, it probably makes sense to do the antibiotics first. You know, do that for a week or so, see if that helps. And if it doesn't, then you can hit them with like a steroid course. You know, usually I do like a Medrol dose pack or something like that, because that way now we know there's no infection. You know, we can just hit them hard with some steroids and anti-inflammatories. Gabapentin's great. It just makes them a little bit woozy and, you know, some side effects, but I love gabapentin. I think it works great. And then meloxicam, any of these newer long-acting anti-NSAIDs, anti-inflammatories works well. I also, you know, I've also encouraged guys to use medical marijuana. You know,
marijuana
medical. There's this vitamin called Canabrex, which is a little play on the words. It's like a natural anti-inflammatory. So, you know, a lot of these patients like homeopathic meds and things like that. And so, yeah, I totally push for medical kind of non-surgical treatments, management initially, and then try to get them to wait 6 months to a year before thinking about like surgical interventions. If they're really, really miserable, you can do a cord block. You know, it's really simple, very effective, and it just gives them hope, because a lot of times the fear is that they, oh my God, I'm going to live like this forever. And so just giving them some reprieve for a little bit to make them feel normal goes a long way. And usually now I've started doing them under just nitrous in the office. So I'm not sure how it is in the UK, whether you guys have access to nitrous, and, you know, works amazing. You know, a lot of dentists use it. And so now in urology, we're using it a lot more. And nitrous is nice because it kind of relaxes them. And so I'm doing even the vasectomies under nitrous now. So these high stress individuals, it won't knock them out, but it just kind of calms them down and stuff. And so even when I do my block, I'm doing that under nitrous, and that seems to just make them feel better. You know, if I can get them feeling better for half a day or a few days, that seems to go a huge way. And I can usually get them to avoid doing procedures down the road just by buying us some time. So that might be something that, you know, I'm not sure if the GPs can do that, or you'd be interested, but that might be something worthwhile considering.
Yeah, thank you, Sijo. I think we're going to have to move on for the next presentation. Maybe just a word that, based on my experience, people who have pain don't have always a similar pain. And the physical exam is key to identify where is the pain coming from. Is it coming from the epididymis, or is it coming from the surgical site? And this will help your approach, your treatment approach. Thank you very much.